And welcome to the Dr. Bob Show. The leading cause of death in the United States is cardiovascular disease. We're very familiar with the terms heart attacks, angina, heart catheterization, stents, revascularization. But what happens to somebody after they've had a heart attack? You know, that may be the most important time because it's pay attention. There's a lot of things we need to do and a lot of people don't pay attention. My guest is Dr. Josh Todd. Dr. Todd is a board-certified cardiologist, and he'll be answering our questions on the whole spectrum. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about how do I teach my children to protect their hearing and shingles. There's a new shingles shot that we should all be taking. Do you know what shingles are? We'll be learning about that too. A lot of information for you. You'll want to stay tuned. We're talking with Dr. Josh Todd, board-certified cardiologist, and we're going to be talking about a wide gamut of heart problems and then walk into maybe the most important. Josh, welcome to the Dr. Bob Show.
Thanks for having me again, Dr. Bob.
Tell me, what is angina or angina? Which one is it?
It's tomato, but there's no wrong way to pronounce it. Angina is a term which we confuse patients with, but it's supposed to describe pain associated with the heart muscle that doesn't receive enough oxygen.
So that's when does it not receive enough oxygen? When you're exercising?
Exercising can. So we've got two different ways people can develop heart attacks. One is the slow progressive narrowing of arteries. And so the typical chronic stable angina is I go exert myself, heart has to work harder, and then because the sprinkler system doesn't work so well, we get heart cells that are unhappy. Those cells tell the brain to kind of slow down, and that's what angina or angina is at that point. Symptoms typically are a squeezing sensation, pressure sensation that radiates to the back, sometimes can refer to your left arm with an achiness.
How long does it last usually?
You know, and then the chronic stable angina setting, it's as long as you're exerting yourself, typically goes away with rest, which is different than the heart attack setting.
So what if I was getting angina and I decided I'd go out for a walk and I went up a little hill and I exerted my heart? What would the pain be like?
Yeah, pain should be more mild in intensity. Most of the time, there are not a lot of associated symptoms, nausea, sweating, vomiting, all of those things.
So
a little mild shortness of breath, maybe.
So what's a heart attack? Angina or angina sounds like a heart attack. What's a heart attack?
Yeah, angina is kind of your early warning sign, lets us know that there may be some blocked arteries, but a heart attack is a little different mechanism. Rather than the slow progressive of narrowing of the arteries, you have a cholesterol plaque. And that cholesterol plaque, for whatever reason, and we haven't figured it out yet, decides to rupture. Your body trying to keep blood from spilling out. So if you get an arm, cut on your arm, blood needs to clot to keep it from bleeding out. Problem is when that happens on the inside of the artery at the heart is that it obstructs blood flow. And so then we've got no blood flow to the heart, and then that's where the rest symptoms and the intensity of the symptoms can worsen.
So if somebody's not getting any blood through one of the coronary arteries, the artery that supplies the heart, with symptoms?
Yes, same type symptoms, but much more intense. And again, you're going to get more of a moderate to severe pressure, squeezing, radiation to jaw, neck. But a lot of times we see shortness of breath and nausea, extreme sweating that can occur with these patients. And they're usually not doing anything. They're sitting in a chair when it happens.
So why do we always say things like, that's the time for 911, swallow it? Tell me what you do in that emergency situation.
Yeah, I mean, we see a lot of patients come with heart attacks all the time, and I think the worst thing you can do is try to drive yourself or have a loved one drive you, because rhythm disturbances can happen in the middle of a heart attack, and it can happen 2 minutes or 30 minutes into it.
So what does 911 do to prevent that?
Well, 911 doesn't necessarily prevent the rhythm disturbance, but they can save you if you have a rhythm disturbance. Plus, they have people trained in CPR, and they can get your heart rhythm back.
You call the hospital and say, be ready, here, we're coming?
Exactly, and a lot of times, all of the trucks now that bring us patients have the ability to do EKGs, which diagnose the heart attack immediately. They send it electronically to us, and we're driving in at the same time the patient is.
So that's pretty crisis management, as I call it.
Mm-hmm.
So when you arrive at the emergency room, do you have to sign in and wait a while?
It kind of depends on the time of night. So middle of the day where everybody's there, you're going to go straight to the cath lab because everybody's there and waiting on you.
So you're going to go straight to the cath lab. Mm-hmm. when 911 has brought you there, have they started any medicines before you go to the cath lab, or aspirin or anything?
Yeah, the aspirin is always given. Sometimes we'll give some nitroglycerin, which can help lower blood pressure, reduce workload of the heart. We're moving a little bit away from morphine now because it can even activate platelets and worsen heart attacks.
We're getting smarter every day, basically.
And oxygen too. So again, ideally the cath lab is the best place. We try not to stop in the emergency department now if we get a heads up that it's a definite heart attack.
So tell me about the cath lab. If somebody says, you know, if I say, well, I think I'm having a little indigestion and it's I'm having a heart attack, and they say, we're going to take it to the cath, that'd be pretty scary for me. What's the cath lab like?
So cath lab is, usually we have three people helping me, and there's the nurse that circulates, there's a tech that helps me during the procedure. But the cath lab is an x-ray camera on a table with some screens in front, with a lot of equipment in the background so we can grab things, because not everybody's made the same way.
So when you do the cath, what are you looking for? How does it tell you something?
Yeah, again, the EKG almost makes the diagnosis 95% of the time. Once we get in there, we can either go through your wrist or your groin to get access. We can make it up to the heart pretty quickly within 15 or 20 seconds.
Well, 15 or 20 seconds?
Seconds to get to the heart.
So when you get to the heart, what's your goal?
Goal is to, one, define what the anatomy is. So we're going to take some pictures of your arteries. We've got in our head what your arteries are supposed to look like, and when there's an artery missing. And the EKG can certainly help us define where we think that should be. And then when there's an artery missing, we go straight to it and get wires and balloons and things up quickly.
So when you find a blockage, one of the vessels completely blocked, what are you going to try and do to reestablish the blood flow?
Right. Reestablish blood flow is probably the most important. For every 30 minutes you're having a heart attack or this STEMI or urgent heart attack, there's an 8% increase in mortality. So time
every 30 minutes increase 8%. Keep going. So time is precious.
Time is muscle. Time is mortality. Time is everything. So it's as fast as we can go. We generally, once we get up there, we take a very soft wire and float it down the artery. The plaque is usually soft at that point. We don't want to traumatize the vessel. So once we get a wire or a rail to get the balloon down, then the balloon goes down and we can usually restore flow very quickly.
The balloon goes down.
Yeah.
What do you mean by the balloon?
So we have tiny balloons. The smallest one we have is 1.5 millimeters up to 5 and 6 millimeters.
So 1.5 millimeters, that's less than the size of an eraser. Yeah. The old pencil eraser. Right. So it's really very, very small.
Very tiny.
And you've got a balloon. Is it shrunken down and you blow it up, or what do you do with that balloon?
All those balloons come in a prepackaged box. They're crimped down, and again, we need a low profile to go through a blockage. Once we get across it, then we inflate the balloon, usually with some dye in there so we can see the balloon inflate, but that allows to displace plaque, displace blood clot, goes downstream and washes out.
And where does the word stent come in there?
Yeah, so stent's a way to stabilize the artery. Before we had stents 25, 30 years ago, we would do an angioplasty, and we had very high rates of that artery collapsing and thrombosing, probably 20, 30% of the time.
So angioplasty is just the balloon?
Angioplasty is just the balloon. Now that we have a stent, which is a tiny metal scaffolding, think of it as like the inside of a pin spring.
I call it a slinky.
Yeah, exactly. It's a slinky. So we get into that area. It's again crimped on a balloon too, and it allows you to open the artery but keep the artery stabilized, and so that we don't have the collapsibility.
Different kind of stents?
Yeah, there's two different main types of stents. One is a bare metal or a non-drug coated stent, and one is a drug coated stent.
What drug coated sounds like more advanced. What does it do?
Is. So, when we first started placing stents, we had just a metal object we put in the body. Problem is the body sees that as foreign, and we start to get scar tissue formation on the inside of those stents. And bare metal stents re-narrow. Our chance of having to go repeat work on the patient was up to 15% with our bare metal stents.
So you reestablish the blood flow. Can you see the heart pink up, and when the patient wakes up, he's got good blood flow to the heart, hopefully, and then you let him do what?
Yeah, again, most of the time patient's awake. We have conscious sedation, so patient knows what's going on. We like to see the EKG changes come down immediately, and 80–90% of the time patients almost have immediate relief of their chest discomfort.
So eventually they go back home and they don't have to do anything, or that's the time to get down to business?
No, that's the time we need to make big lifestyle modifications, diet, exercise.
That's what we're going to be talking about. Lifestyle modifications. We've all heard those words. But how many people actually take advantage of that? And if they don't, they might die. You want to stay tuned. We're talking with Dr. Josh Todd, and we're talking about heart attacks, stents, reorganizing the blood supply to the heart. And then everything is all right and the person's great, but that's a time for lifestyle changes. Josh Todd, what's it like when you tell somebody that, yes, they're now doing well, but now's the time to get to work? How do you tell them what is it like?
Yeah, normally I come in with a patient and tell them there's things I'm going to do for you. We've established flow and I've got these medicines and you're going to do really well with them. But part of it is the patient's decision. One, to be compliant with medicines. Two, to change bad habits, modifiable risk factors like tobacco use and dietary decisions. And then how do we get your heart moving again and get you exercising?
So cardiac rehab. What is cardiac rehabilitation? What do you do with that?
So the rehabilitation sometimes gets a little misnomer. We just think it's an exercise program, but really it's kind of a three-pronged approach. We try to tackle, yes, the exercise potential, but diet, tobacco use, all of those decisions that people put in their body. And then there is a better known process of depression that happens immediately after a heart attack that needs to be taken care of too.
So depression is common.
Depression is very common after
So
heart attack.
in lifestyle changes, part of it is mental counseling or mental guidance?
It's a little bit of that, but you're again in a situation where everybody there has had a heart attack. Everybody's gone through the same thing, so it's a support group and mental guidance all at the same time.
So when I see people that've had a heart attack, they're scared to do anything. And so you say, we don't want you to do that. We've got to get things reestablished. I'm going to send you to cardiac rehabilitation. How many people end up going?
I think it depends on, one, how quickly we can get you in, okay? And we'd like to try to get you into cardiac rehabilitation within the first week.
First week after a heart attack?
After heart attack, yeah.
So you can get back and get with it within a week or so?
Yeah, and then again, that's the initial evaluation where we're going to take a look at how big this heart attack was. Are you high, moderate, or low risk for arrhythmias? We give you an exercise prescription and really give you the education. That's the most important thing up front.
So with exercise, what do you have the person do? To me, in cardiac rehab, you get on a treadmill and they decide how much stress to put on the heart. They keep you below that, and everybody else is there talking about their heart attacks and joking.
So we have different ways. We've got lots of people that aren't ambulatory. They can't walk after their heart attack, so we have hand bikes that they can use. It's not always treadmill. We have recumbent bikes, and so we can always get the heart rate up in some form or fashion.
So you want to get the heart rate up?
We want to get the heart rate up, but not too quickly, too fast. That there's an exercise prescription, and usually we go to about 75% of your max age-related heart rate. And so based on age, everybody's got a different target they need to hit.
So every individual is different. It's just not throw them in a cookie cutter approach. No. So what's the usual duration? How long is cardiac rehab? Is it 3 weeks? Is it 6 weeks? Is it 6 months?
The longer you're in it, the better you do. Now, insurance companies will give you about 36 sessions after heart attack before they may move you to a phase 3 rehab. And the difference between phase 1 and 2 and the phase 3 is the amount of monitoring that you get. For the first sessions, we put you on a cardiac monitor to make sure we don't have cardiac arrhythmias. Read a statistic, we save about one life for every 1 million patient exercise hours. But it does happen after heart attack, and if you're having a rhythm disturbance while exercising, you want to be near electricity. You want to know that you have it immediately so we can get you back.
So if we've got two groups of people, one that says I had a heart attack and I'm okay, I'll go through cardiac rehab, and the other one say I've had a heart attack, I'm feeling so good, I don't need to go through that. I can get back to work. I'm hard driving and I got things to do.
Right.
What's the follow-up on those two groups, the one that went to rehab and the one that didn't?
Yeah, the ones that don't go to rehab, there's at least 20 to 25% increased risk of readmission, or even
with a heart attack,
or death from a cardiovascular cause at a year. So you get a 30% chance of not being there a year or coming back in the hospital again.
And with cardiac rehab, you've got a much better chance of being there the next year.
You do.
So how long probably is the rehab, depending on insurance?
Yeah, the minimum is 36 sessions, usually so about 6 weeks of time, assuming
You
3
do it
times a
every
week.
day, 36 sessions?
It's usually 3 times a week. We can do more, but I think our patients that really do the best. I mean, I've got patients that had a heart attack 2 or 3 years ago, and they do a phase 3. They come in, they've got their friends, and it's relatively inexpensive for phase 3 rehab. And it's like going to a gym, but you're with people that you know and exercise with.
That had the same problem that you had of doing better, and it gives you
Yeah.
more encouragement to do better.
And you can encourage other people, which helps the mental process of developing this.
So that's exercise. Then you said one of the avenues is nutrition.
Correct.
Do you have a nutritionist? Do you have what kind of counseling do you have for somebody that have to relearn how to eat and lose weight and get their BMI and get off the couch?
Right. We definitely have a nutritionist dietitian that comes in. It's an evolving subject now. We used to go down the low fat, low cholesterol diets. Now we're starting to teach more lower carbohydrate, Mediterranean style, plant-based diets. So, the
Fruits and vegetables and nuts, and stay away from the bad food and eat the good food.
Exactly. Lean proteins, green stuff, stay away from the carbohydrates.
People know what they are. They just sometimes don't look at their plate and say, now how much am I going to eat and how much of that is bad stuff?
Right.
So do you have to mainly cook at home to get good stuff? I think probably so.
Yeah, and it's education. Again, you can find at most restaurants some things that you know are good. There's several apps that can kind of help you determine how to make good choices. So I think if you're involved in it, you want to educate, you want to learn about it, you can almost find things to eat anywhere as long as you're cognizant of it.
What kind of changes do you see when people are exercising? They go on a really good nutritional diet. What we'll call it diet, eating.
Yeah, and I think it's, again, multi-pronged approach. You get exercise and the weight starts to come off, and it takes 2 or 3 weeks for most of these people to kind of get into a system and kind of get it so they start feeling good. And then they get to a point where they're, I love to keep doing this, I don't want to go back. And so they kind of maintain it by themselves without much pride.
Got anybody in your mind, we won't mention their names, who was really a superstar and lost 20 pounds and were able to do almost anything they wanted, and their electrocardiograms turned back to normal? And
I've got people that have lost 85 to 100 pounds after their heart attack. It's a life-changing experience to have a heart attack.
And they also learn to appreciate every day as a new day. And they've got the mental counseling against depression. So risk factors, quickly, what are the risk factors going to be?
Yeah, genetics are 60 to 70% of it, but the modifiable risk factors, the things we can do about age, unfortunately we can't do anything about that. But
I'm getting in the age bracket.
So smoking is certainly one thing.
Smoking kills.
Yeah, it does.
So you've got to be able to stop. You've got good programs to stop smoking?
Yeah, we're getting better. Again, it comes down to patients wanting to quit. If they get to the point of wanting to quit, we've got a lot of things to help you, but you got to get to that point.
Other risk factors?
Other risk factors certainly are high blood pressure and diabetes.
We've got lots of good medicines for that.
Right.
Diabetes, you want to get the blood sugar down, or your hemoglobin A1C down. If you don't, you got diabetes and you got big time troubles with that. So are we very effective in taking care of those risk factors?
Yeah, the diabetic medications have come a long way. Our cardiovascular medicines, it's still statin, and aspirin. But as long as we have people adhere to these things, we have pretty low rates of recurrence of coming back to the table after a heart attack, less than 5% at 5 years with a stent that you're coming back to see us again.
Obesity and sedentary lifestyle.
Right.
As part of the risk factors. In our nation, we're getting more overweight and more overweight. And so if people start at an early age, is that that's something they can do to prevent the heart attacks at an early age. What would be your overall summary? What would your advice be to people? You're young, you're thin, you eat well, I'm betting you exercise. What's your advice to the public? Because we're going downhill.
Yeah, the intake into your body is the most important thing, I think. And people try to lose weight or use an excuse of I can't exercise, therefore I can't lose weight. But if you don't put it in your body, the weight gain won't happen. Exercise is a little more difficult. People think if they can't go out and exercise 2 hours at a time, then they're not doing their body any good. Not true. There's been a trial looking at no exercise to low to moderate intensity exercise. And actually there's a benefit to 15 minutes a day or 90 minutes a week. There's still cardiovascular benefit. Less than that, probably not, but everybody can get into 15 minutes of moving around on some level a day, period.
Must be great to look at a patient that's had a life-threatening illness and to be able to come back and say, Dr. Josh Todd, you saved my life.
It's good. I'm glad I came now rather than 30 years ago when we couldn't do anything with a heart attack except for watch you. But technology, medications, everything has really progressed to the point where you've got a very good chance of a good quality of life in addition to survival after a heart attack.
Josh Todd, thank you for coming to the Dr. Bob Show. Thank you for teaching us. You're a great teacher. Thank you.
Thank you, Bob.
Remember, you need to take care of yourself. Now you're going to want to stay tuned. We're going to be talking how do we protect our hearing or we don't get deaf later on, and shingles, new vaccine, new treatment, same old illness. Do you know what shingles are? 1 out of 3 people are going to get it. You'll want to stay tuned. I want to thank Dr. Josh Todd. Wonderful discussion on how to handle chest pain, and heart attacks. Thanks a lot, Dr. Todd. And now for questions from you, the viewer, that I think will be important to your health. Question number 1, Dr. Bob, how can I teach my children to protect their hearing? I didn't hear you. You know, as we get older, we frequently have people say, huh? What'd you say? I can't hear you. I don't understand what you're saying. Sometimes we get in a crowd, and when we get in a crowd, we can't differentiate the person that's talking right in front of us because of background noise. It's all because of the damage that we do to the ear as we grow up. So the hearing mechanism takes sound, reproduces it up in the brain, and so that we can hear words and pitches and music and all that. But if we traumatize the eardrum, then we cause damage to the inside of the hearing organ. And once there's damage done to what we call cilia, little hair-like follicles, once they're burst, when the loud noise goes boom, boom. And by loud noise, I don't mean just concerts. I mean machines that you're using at home. It may mean the earphones that you're using. They're all significantly hurting your ears and hurting your hearing. So be careful. Be sure that if you've got ringing in your ears after you're hearing loud noises, that you know there's been damage. There are little type of protective mechanisms, little objects that you can put in your ears to buffer the sound. So take care of your hearing now so you won't have trouble later on and somebody will say, you're not listening to me, why can't you hear? And then you end up having to have hearing aids. So protect your ears now. It'll be worth hearing later on. Remember, we say a stitch in time saves 9. So if you work on it now, you're going to be better later on. Question number 2, Dr. Bob. Shingles. Is there a new vaccine? Shingles is due to a herpes zoster or varicella zoster virus. We get chickenpox in childhood if we get our chickenpox vaccine. So if you've had the vaccine or you've had chickenpox, we're living longer, so our immunity eventually goes away, and we don't have immunity against getting that same chickenpox virus that hides in the nerve endings. And we don't know how it hides there, but we do know that stress or poor nutrition or who knows what will suddenly in a skin dermatome begin having little stinging sensation. It can be in the face, it can be on the side. It's always just essentially always one side. And then you break out in little red blisters, painful, itchy, burning blisters. And if they're not treated immediately after those little blisters, you can get after shingles pain. We call it post-herpetic neuralgia. New vaccine. The old one was Zostavax. Probably not as effective as the new one. The new one's what we call recombinant, and it works. And we should now set the clock back. We should start getting it at age 50. So your doctor will have new recommendations. At 50, you get Shingrix, Shingrix. And what it will do, it will prevent you from getting shingles, or if you get shingles for sure, it will make you have less chance of getting after shingles pain, post-herpetic neuralgia. So talk to your doctor about getting Shingrix. Age 50. Have you had your vaccination? We're now learning that vaccinations prevent lots of problems. We'll do a show on adult vaccinations. We're pretty good at children, but we're not very good at adults, like the flu shot every year. Well, that's all the time that we have for this show. Remember, we need to be exercising. It's going to help your heart. It's going to help after a heart attack rehabilitation. So exercise will cut down on stress. It'll lower your blood pressure. It'll make you feel better. You'll do better. It's probably the number one most good thing that you can do for your health. Relieves anxiety, gives you a runner's high. Be sure you're eating properly. Remember, you can tell by looking at your plate whether you're eating good foods or not. The Mediterranean diet that we talked about is mainly nuts, fruits, vegetables, no fried, fatty, greasy foods. Start off with a breakfast that's a good, nourishing breakfast, but don't have a lot of greasy stuff. Eggs are okay. Protein's good. And then start eating less, and don't snack before you go to bed. And get rid of bad bread and get whole grain food. So talk to your nutritionist or your doctor about that. 7.5 hours sleep. Nah, I don't need 7.5 hours sleep. Yes, you do. You need that, or maybe even a little bit more. And so that'll make you rest. You'll feel better. You'll perform better. You'll be a more happy person. If you're having trouble sleeping, talk it over with your doctor. It could be pain. It could be your medications. It could be the room's not quiet. So learn how to sleep, get that 7.5 hours sleep, and most of all, what is it we like in the Dr. Bob Show? It's that giggling and that laughter in your life. When you laugh a lot, your immune system will work better and you'll stay healthy.